All right, let's talk about our secondary supraglottic airway devices. Now there's a combi tube, and we're not going to go over that one, but there's also LMA, and I'm not going to go over that. But what we're going to go over is the one we have right now in the system. It's called the King airway. There, for the adult, we usually carry the 3 different sizes, 3, 4, 5. Here you see 3, this is for the smallest patient, and then we have a 4, and then I didn't have a 5, but 3, 4, 5. 3 is for 4 feet people. 4 is for 5 feet people, and 5 is for 6. So 3, 4, 5, 4, 5, 6. 3, 4, 5 are the sizes we carry. They're for 4 feet, 5 feet, and 6 feet individuals. And if you use these, you probably can get away with just this first initial bolus of 60 cc's of air when we inflate these cuffs. So you drop back your 60 cc syringe, and that'd be a good starting point on either the 3, 4, and 5 King tube. Again, it's 3, 4, and 5 for 4 feet, 5 feet, and 6 foot individual. And by inflating the 60 cc's of air, we can see that the distal and oral tube balloons are inflated. So this will go in the oral cavity, obstructing any air from coming back up through the oral cavity. And then this cuff here is inflated. This one goes down into the esophagus and obstructs any air that would be ventilated through the King tube and obstructs the esophagus from filling up with air, called gastric distension. Any air that goes down through the tube then would be expelled through these openings here and right around where the glottic opening sits, and we should have a good rise and fall of the chest. Air should then be displaced and exhalation back through this opening and out through your bag valve mask. One more time. Sizes are 3, 4, and 5 for 4 feet, 5 feet, and 6 feet individuals. So if they're greater than 6 feet, we can use those. These are rough tube sizes, so basically you want to keep one above and one below, just in case you don't get the adequate seal that you needed or the proper rise and fall of the chest. Again, we can start off with about 60 cc's of air, and we can work up. 60 cc's would be the max for your smallest tube size, which is the 3, and then 60 cc's is not even the top of the size for 4, so we can play around by giving another 20 cc's of air for the upside, and we can draw out 20 cc's of air on the lower side if we feel like the balloons are just way too inflated. All right, so we've done our BLS measures up until this point, and we find that maybe our ventilation through our BLS measures have not been as adequate as we would like them to be. We are getting some rise and fall. We aren't getting the color changes that we need. We're doing the 1 breath every 5 to 6 seconds or 10 to 12 per minute, or unless the patient's physiological needs require you to breathe faster for them. But we're just not able to get good airway pressures down. We're not able to get the inflation. The chest is still not adequately has enough air movement in there. So as our BLS partner or our secondary rescuer takes over on the ventilations with the bag valve mask, we'll prep our tube. Again, everything stays inside the packaging, stays pretty much kind of sterile as possible. You want to just drop some 60 cc's of air connected to the pilot balloon, inflate your syringe and balloons so that you can then test the integrity so that there's no leaks. You'd hate to place the tube down and then there's leak around it, or a slow cuff leak or a slow balloon leak, and you're not getting the good airway pressures that you need. Deflate all the balloons again, making sure all the air is out and back purged into your your syringe. And now when you advise your secondary rescuer that you're going to place this tube in, they're going to move things off. You want to have your tube extension, a colorimetric device, as well as your capnography and capnometry device to validate that you're in, and to confirm tube placement and air exchange is going into the lungs and not into the gastrum. So as the secondary rescuer takes the bag valve mask and removes the OPA out, you use like a tongue jaw lift, and basically you're placing this down straight towards midline. They have some indicators there. Basically, you're just going to inflate your cuff and let it situate into place. You can go ahead directly and ventilate by listening now to lung sounds, so you can hear in the epigastrium. So negative lung sound, negative epigastrium sounds, positive lung sounds, positive lung sounds, positive lung sounds, positive lung sounds, negative epigastrium. We also would intend to put on our colorimetric device and our tube extension once we get our breath in. Go ahead and continue to ventilate. One breath every 5 to 6 seconds. Watching for a colorimetric change. And then we can go ahead and discontinue this and then verify with, verify with our our capnometry or capnography, and we're going to continue to ventilate, listening for lung sounds, positive lung sounds, positive lung sounds, positive lung sounds, negative epigastric sounds. I have a good capnography waveform, a square box, reading in the normal ranges. I have good and also colorimetry numbers, and I also have good pulse ox exchanging numbers on our EKG. So just to reconfirm, we did place the colorimetric device on prior to putting the capnography and capnometry device on to confirm our lung sound placement. Prior to that, we needed to get our breath on, so we listened to the breath so that we could make sure that we confirmed positive lung sounds and negative epigastric sounds. We had our tube extension placed off, and we went ahead and placed our King airway here by inflating 60 cc's of air. Tongue jaw lift, line of sight, and then we had an OPA that was placed in prior to this, and our rescuers were helping us to assist with ventilations with one breath every 5 to 6 seconds. Again, we weren't really pleased with the numbers that we were getting. We weren't able to get good mass seal maybe, or we weren't able to get good excess rise and fall, and the extension of air to the base was poor, so we had less airway pressure that we could give, and so we went and decided that maybe a secondary device was used. Now, one of the reasons why we can't use this is if they have a gag reflex, they're gonna gag on your OPA, they'll probably gag on your King. This may also be used if you have some type of other massive facial trauma where this balloon may be a problem and it won't be able to inflate and secure the airway. We may not try to use that. And then if we think about corrosive or caustic substances that the person may have ingested, we don't necessarily want to cause air to be displaced. So if we place this in the wrong position, we may ventilate too much air down into the stomach and it may displace the contents. So these are some relative contraindications. It doesn't necessarily mean that we can't use it. It's just think about it when we're placing this in. Again, if you don't get good airway pressures and you're not able to get good rise and fall, you got a lot of cuff leak, you may end up increasing the size a little more, because we can give more than 60 cc's of air, up to about 80 to 90. We can also allow this thing to migrate in the patient, and we see some bite marks here where we would look at the lip to tip depth. So we can play around with this. If it doesn't work, take it back out, BLS for a while, and then consider a size either larger or smaller depending on how far down you were able to place this. So if you were placing this really far down and you're not getting any good air movement, you may have gone past the back of the oral cavity, the hypopharynx, and you may be down now, way down near the glottic opening, where now you're obstructing too far down. In some cases, it may not be far down enough, and so we're not ventilated in the correct placement. So that's where we're saying just make sure we try a different size and think about how we're placing this.